So this is very simple presentation, and very interesting thing in my presentation is that I have learned to make PPTs by myself. This I was knowing earlier also, but I have also learned how to put pictures in it and how to write down the titles in it. And whenever you learn something new, it is going to improve your even cognitive functions also in this age of time. So we should learn every time. You should. So the learning is also new learning should always be there in till lifelong. What I feel, it is nothing like academics only. You can learn anything which is interest to you. So this gives happiness. Yes. So this presentation also made for DNP students only, but it was liked by the person who has called me very much. So I thought I should share this presentation to you also. So I am going to discuss this topic into these points, that menstrual cycle, how does it being regulated, and how does a cessation of bleeding occurs when menses stops, and what is the definition of AUB itself, and how it is classified, and how will we evaluate, and what is the management, and what is the role of histoscopy in AUB. I am going to discuss this topic into these points. And the first thing I would like to share that we are seeing 30 to 35% of patients of AUB almost according to literature, but when we see the difference, what difference has occurred in the classification, you will see that even 50 to 60, 70% patients which we are seeing in gynae are AUB. So how does मेरा एक तो चला गया, first वाला तो चला गया. How menstrual cycle is being regulated? We all know that it is being regulated on 3 levels, from hypothalamus, pituitary, and then ovary, and then to the endometrium. So there is a synchronous changes in a synchronized way. Then only and when this synchronicity is absolutely in form, then only it is the normal bleeding. But wherever it goes wrong, then we have this abnormal bleeding. And how does it stops during after 5 days of bleeding? That there is a withdrawal of estrogen, sudden withdrawal of estrogen and progesterone leads to shedding of functional endometrium and exposure of basal layer. When the functional endometrium goes away, there is exposure of the basal layer, which leads to stimulation of coagulation, and this coagulation causes vasoconstriction and epithelial reconstruction to limit the volume and duration of the bleeding. So in response to cyclical sequential estrogen and progesterone stimulation, growth and development of endometrial epithelium, stroma and microvasculature is stable and it does not break down randomly. So it is being controlled. So sequence of events leading to enzymatic changes also occur in the endometrium itself, will proceed in the orderly or synchronous fashion. Endometrium is not only repaired, it is completely remodeled, it is changed altogether in every cycle. So what is the definition of AUB? First of all, we have to exclude the gestational kind of AUB. You will call AUB only when it is non-gestational AUB in the reproductive years, and it is defined as bleeding. ये भी गलत है. Chronic, like it is being divided into two, acute and chronic. Acute, we all know that any bleeding which interferes in the quality of life acutely, or it needs the immediate intervention by the doctor to control. Otherwise, it is going to be dangerous for the patient. It is acute AUB, and chronic AUB is when it is defined in the duration or in the days, duration, amount, volume, and irregularity. It should be regular. These things which we were previously knowing this terminology, now these things have been changed. We are no more using this terminology now, but we should know what we are knowing from ages. Polymenorrhagia is frequency that is less than 21 days of menstruation at regular, but it should be on regular interval. If it is less than 21 days, every month, it is polymenorrhagia. Menorrhagia is excessive and prolonged menstruation at regular intervals. Metrorrhagia, uterine bleeding occurring at irregular and frequent intervals in variable amounts. And menometrorrhagia is excessive or prolonged bleeding at regular intervals. Intermenstrual bleeding is bleeding of variable amounts occurring between regular menses. Hypomenorrhea is scanty menstruation, oligomenorrhea, infrequent menstruation, which is more than 35 days of cycle, and amenorrhea is absence of menses for 6 months. Postmenopausal bleeding is bleeding that occur after more than 1 year after the last menses. This is summary of FIGO 1. There are two systems. FIGO 1. There are two systems which we are using now in the FIGO classification. System 1 tells you about the history which causes this duration, irregularity, amount, volume. That 4 points has to be asked in the history. Then you will tell that these are the abnormality in the system 1. And system 2 is when what palm point we have learned earlier. That palm point, what exactly it is in the system 2. That will be known after your complete examination, after your investigation. Then only you will come to know for the diagnosis of your cause of AUB. That means that system 1 is only for symptomatology and system 2 is for diagnosis. So frequency should be, and we all know that FIGO classification was started in the 2011 and it was implemented in 2014. And in 14, again the people have started to change some terminology and they sit together to see what improvement can be done. So FIGO classification again updated in 2018. So that minor changes which has happened in FIGO 1 or FIGO 2 classification, I am going to tell you that. So the frequency is amenorrhea, which we were using separately from the AUB, is now included in FIGO 1 classification. Amenorrhea is also included in the AUB and it is in the system 1 frequency point it has been included. So regularity, normal variation of 7 to 9 days. Slight variation depending upon the age is supposed to be the normal, but if it is the variation is more than 7 to 9 days, it is abnormal. 7 to 9 days means the patient is having a cycle of 28 days. So she should not have 4 or 5 days early or 4 or 5 days later. So total change may be 7 or 8 or 10 days, but 4 to 5 days she should not have earlier and 4 to 5 days she should not have later. So this is change in the duration. And duration, we were using in FIGO 1, the duration should be 2 to 8 days. But now in new classification, they have told that any bleeding, if it is more than 8 days, is abnormal. If it is even for 1 day, it should be taken as normal. Patient usually come to us that what come bleeding only for 1 day or 2 days. We can very well tell them that this is normal, it should not be more than 8 days, then it will come into abnormal uterine bleeding. And what is the volume? Definition of volume, previously we used to read the previous classification, it is 80 ml. But now 80 ml or 35 ml, it is not nothing like that. Any bleeding which is bothering a woman, whether it is very less or whether it is very much, and it is causing the change in the quality of life. So that may be taken as abnormal. Intermenstrual bleeding is spontaneous bleeding between menstrual cycle, which can be cyclical or it may be random. So this is a system 2 classification. And what are the changes? If we all know this ongoing classification, I am going to in detail now, one by one, to tell what has changed in the system 2 classification. So whenever we are talking about arm point, that means we are talking about system 2. And what has changed in system 2 from 2014 classification to 2018 classification, this I will going to take. This is system 2. In system 2, if we are talking about adenomyosis, now the sonographic findings in adenomyosis have been absolutely clear now, and we can diagnose your adenomyosis during transvaginal ultrasonography, and which I will tell in detail what are the diagnostic points in transvaginal ultrasonography, which are the diagnostic of adenomyosis. And AUBL is inclusion of type three. Initially, in submucous myeloma, we used to see that type 0, type 1, and type 2 was supposed to be in submucous classification. Now, type 3 is also included in the submucous type, because this type 3 also, any myeloma which is touching to the endometrium is supposed to be the submucous myeloma. So, this type 3 myeloma is also touching slightly to the endometrium, and so they have included this type 3 also in the submucous myeloma. And previously we were including all AUBs because of any pharmacologic agents, any anticoagulants medication also in the coagulative disorders. But now these patients who are on the anticoagulant medication or any other medication which is causing bleeding is in the iatrogenic AUB. But now it is no more in the AUBC. Even if you are giving heparin or anticoagulants like warfarin, they are also not included in the coagulative disorders of coagulative disorder causing AUB. Only cognitive disorder, von Willebrand's disease or any these kind of things will be in hemolytic disorders. They will be included only in the AUBC. And very interesting point is that AUBI is now includes AUB associated with the all iatrogenic process, IUCD which we are putting in. So IUCD if we are putting, that will also cause AUBI. So that is why I was saying AUB incidence has increased because classification has some changes. And AUBO, diagnostic threshold change based upon the system, that it does not include anything causing any medication which is causing ovulatory disorder, including hormones which we are using, OCP, any kind of this thing will be including in the iatrogenic, not in ovulatory. Ovulatory is only when ovulation disorder is there, and that is one very important point is here, that to diagnose whether this AUB is ovulatory or non-ovulatory, there is no role of endometrial biopsy. Endometrial biopsy is to be done only when it is indicated for patients you want to know that hyperplasia may be there, or after 40 years of age if you are thinking of. But to diagnose whether the patient is having ovulation or not having ovulation, there is no need of doing endometrial biopsy. So, ovulatory disorder only when there is disorder in ovulation because of some mechanic disorder, not because of any drugs. And AUB, and is previously we used to say that AUB is not yet classified, but as if that we are going to classify this AUB later on, but now it has changed to terminology AUB, otherwise not classified. So one by one we will discuss. The polyp is only polyp that are exophytic growth of mucus lining of endometrium, and they may be different in shape and sizes. They may be present in around 25% of women, and they differ from the submucosal fibroids in surface epithelium and vascularity, which is similar to the endometrium, surrounding endometrium. And hysteroscopic removal is very easy. This is a picture of polyp, and we can see that endometrial epithelium is surface is same as the endometrial surface. Now there is some changes in the classification, leiomyoma submucosal classification. So submucosal, I have already told submucosal classification. The third one is that is in the shaded gray area. That is that third you can see that third key number where it is written that this third number is touching the endometrium. So it has come into the submucosal classification. 4 is absolutely myometrial. This is myometrial and intramural and subserous. And 5 you can see that it is subserous, but less than 50%. This is very much seen in the picture that less than 50% of fibroid is subserous. Rest is in the myometrial. And 6-1 is that more than 50% is going outside the subserous, and rest less than 50% is inside. And 7 is this is penetrated fibroid, we know that. And 8 is wandering hole, it is cervical hole, it is in the broad ligament, any kind of. And very interesting thing is hybrid fibroid. The two, and you have to write down this, and you will see the ultrasonography picture. You should and less than 50% is going to the outside. So you have to write down 2-5. So 2 will present inside and 5 will present outside. So succeeding so this has to be limited to all of us as gynecologists so that we can discuss this with our patient. This is my surgical descriptive picture. So my brain, maybe some intramural also big one. This is also very no broadly this is very and what interests me more that this picturization of this is present in my computer specification what it is. Postal wall is bigger than the anterior wall. And in the postal wall where I have itemized there are biometric cysts. And in C there hypericonic cysts. More in fat and cavity. And endometrial lining and birth to be present. And all things are present in the postal wall because itemized there. And in F there is translesion vascular. And G you can see that there is irregularity in the junctional tube. Junctional tube is endometrial and biometrial junctional tube. Usually they should be regular, but when you see this, there is irregularity, you can think of adenomas. And sometimes there may be interruption in the junctional tube. So this is my can you see the thickening of the myometrium and and you will see that the junctional zone are also irregular and lower part is sick somewhere in the London. This is very interesting. When you know the things, you can correlate the things. But I was not doing this with of adenomyosis. So I was not able to correlate my findings with the specimen. Now AUB-M. Women with AUB and associated malignant or pre-malignant lesions, they may be endometrial hyperplasia, endometrial carcinoma, leiomyosarcoma, or atypical endometrial hyperplasia. Sometimes we refer it in a sort of a cut radius, right? Somewhere refer to an endometrial intraepithelial lesion. जैसे हम CIN बोलते हैं, endometrial intraepithelial lesion. These are the histoscopic finding of endometrial hyperplasia. Now, how will we evaluate? Screen for coagulopathy. Screening. And in history, we can ask that screening of coagulopathy, we have to ask in the history in every woman of heavy menstrual bleeding, especially in the girls, adolescent girls. And in initial screening, there should be structural history. Positive screening result comprises that heavy menstrual bleeding since menarche. We can think of that there may be some cognitive disorder. And if she has delivered, there may be postpartum hemorrhage, surgical related bleeding, or bleeding associated with the dental work, or 2 or more of the following symptoms: like bruising 1 to 2 times per month, or epistaxis 1 to 2 times per month, and there may be frequent gum bleeding, and family history of bleeding symptoms may be present. And patient with these positive screening should be considered for further evaluation in terms of cognitive disorders. And what are we are talking about the point partner cognitive disorder I have discussed. Now we are going to discuss ovulative disorder. What may be? Whenever the patient is having the regular cycle, most of the time they are ovulating. And anovulatory cycle are usually irregular in time and duration, and there may be a period of amenorrhea before the bleeding. If largely based on AUB system 1, a woman is found to have AUB related to ovulation, P is not required for diagnosis of ovulation. Anovulation causes, we all know that there will be hyperandrogenic anovulation, PCOS, congenital adrenal hyperplasia, androgen producing tumor, and there will be hypothalamic dysfunction, hyperprolactinemia, thyroid disease, premature ovarian insufficiency. And medication affecting ovulation are now included in the androgenic causes. So endometrial causes of AUB are, there may be endometrial inflammation, endometrial infection, endometrial tuberculosis, and abnormality in the local endometrial vasculogenesis. That is also because of some infection or chronic or acute infection or inflammation. Iatrogenic AUB is associated with the use of selected categories of systematic pharmacology or intrauterine devices. I have already told that iatrogenic IUCD वाला हो जाएगा और genital steroids या estrogen, progesterone, androgen agents that we use in our any kind of treatment that will also be included in the iatrogenic causes. In the original categorization, AUB associated with the anticoagulants were included in the cognitive disorder, but now it has come into the iatrogenic causes. Especially when you are giving anticoagulants or some even tumor anticoagulants also. This I have told that the category and not otherwise classified was created in the original system is now otherwise classified. This includes AV malformation or lower segment of upper cervical niche or stenosis or which is associated with the previous cesarean delivery. And how will we start evaluation of the AUB patient? Evaluation for AUB ensure that feeding is not affected of the pregnancy and complete history of like fever system 1 has to be taken and by history only first you diagnose whether it is AUB or not. When you think that it is AUB, then you have to go further in the system 2 for the cause, for the diagnosis of cause and treatment. Women should be evaluated for iron deficiency anemia and that has to be corrected first and then systematic evaluation according to the PIGO AUB system 2. ये भी अपडेट होना ना इस बता सकती मैंने बोला था कि मैं इसमें करना चाहती हूँ. How will you evaluate the uterus? You have to see whether hyperplasia or hyperplasia, then you have to go for endometrial biopsy. You have to go for further invasive test or hysteroscopy or endometrial biopsy or endometrial aspiration when you are not able to diagnose by ultrasonography. Then you can go for endometrial cavity is normal. You can see that this is normal. If there is imaging feature that indicate the presence of endometrial clotting or there is myoma or that may approach the endometrial cavity or if the examination is suboptimal, imaging and more sensitive tests. So these are hysteroscopy or transgender ultrasonography, intrauterine path with either gel or saline and you know that sonography has to be done. Office hysteroscopy is available, then we can go. We will take complete history, examination, and we will do the investigation then and there. And we will also recommend this. MRI is only required when you are not able to reach the diagnosis. So, what you can do in one topic examination history and examination ultrasonography and office hysteroscopy you can do. Then and there, even you can do endometrial aspiration. So all can be done together. So treatment, medical management is the first choice. First to be started for all cases. Only when a very big tumor is there which is causing pressure symptoms, you have to go for surgical treatment. And that is bed rest, correction of anemia, blood transfusion if needed, do it. And treatment of cause has to be done. Medical management, we all know, non-hormonal and safe and prostaglandin synthesis inhibition like mefenamic acid, naproxen, ibuprofen, antifibrinolytic tranexamic acid or Teflon, which is venotonic, and hormonal treatment we all know. These are all we all know we are using estrogen, progesterone, using androgen, GnRH agonist, GnRH antagonist. Rather now we have seen that antagonist is for much better effect than the agonist. And for this medical management of the AUB with the entirely different topic. So I have not closure of growth rates, so height of girth will be stopped, but they say that 95% of growth occurs by the menarche. So you can go for and life-threatening things has to be treated first. What is the role of hysteroscopy? Hysteroscopy has opened new dimension in AUB. intracavity lesion can be accurately identified and treated simultaneously in office spectroscopy. Endometrial tuberculosis, AV malformation can also be diagnosed. And new fiber optic is small caliber endoscopes, simpler distension media. Now we all know that previously for any surgery we were using glycine. Now we can do with the bipolar cautery we are having. This can be done by normal saline. Take home message is surgery only when medical treatment fails or contraindicated or it cannot be tolerated by the patient. Endometrial ablation should not be the primary therapy because it hampers the other common methods of treatment, and monitoring of the endometrium is also not possible by doing the ablation in the first go. And low dose COC 20 to 25 microgram ethylene estradiol is mainstay treatment for adolescent girls. And low dose COC and progesterone therapy effective for 13 to 39 years and 40 years and above, but prior to menopause. Low dose COC, cyclic progesterone or IUS may be the treatment, and office endometrial biopsy is preferable rather than DNC. And when medical treatment fails, then family completes, then we can go for definitive surgery.